Hi, my name's Lynn Davis. I'm one of the midwifery lecturers here at Staffordshire University, and I'm going to talk through a breech vaginal delivery. So you will have had the theory prior to this to support the information that I'm giving you. This is just going over the breech manoeuvres for spontaneous vaginal breech delivery. So the first thing I'm going to do when detecting a vaginal breech is I'm going to call for help. And as you can see, I've removed the bottom of the bed. I've brought Lucy's bottom to the edge of the bed, and I'm going to wait for some staff to come and support me. Now, we know that better outcomes happen when senior members are present, so I'm going to ask for a senior obstetrician, and we're also going to want our senior midwives present, and we're going to want the neonatal team here just in case baby needs any neonatal resuscitation at delivery. Okay, so I've called for help. I've taken off the end of the bed. Hi, this is Lucy. We've got a breech delivery, yeah, baby, she's fully dilated. Baby is descending well.
Okay.
So we've removed the bottom of the bed, and we're just now waiting for the next contraction. So we'd be constantly encouraging the mother and doing our routine observations, so 5-minute auscultations of the fetal heart, and obviously doing our routine nice maternal observations as well. We're going to wait for the buttocks to descend. With contractions we can encourage just normal active pushing, so for the woman to go with her body. And if the legs can deliver spontaneously, then that's exactly what we'll do. If not, we might need to pop some pressure on the popliteal fossas, so the back part of the leg. So then as we pop the pressure, we can sweep the legs up and out, and then the same with the other side. So on the popliteal pressure, and then we can sweep the legs up and out. What we need to do is we need to ensure the baby is sacro-anterior. So what that means is that the back is uppermost throughout the whole delivery. So holding the bony prominences, I'm going to turn the baby round so we know the baby's back is uppermost. And now I'm going to wait for delivery of the scapula. So I'm going to wait to see the shoulders. So I'm going to encourage Lucy to continue pushing with contractions.
Well done, Lucy.
So until I can see the scapula. So the same as the legs, if the arms can deliver spontaneously, then that is great. We want it to be as hands off the breech as possible. We don't want to be stimulating the cord, we don't want to be stimulating the baby to take their first breath. But we can see now we've got 5 minutes from the birth of the buttocks to the birth of the head for a safe delivery. So if time is ticking and the arms aren't delivering, then we may need to help. And what we do is we put pressure on the antecubical fossa, and we use what we call love sets manoeuvre. So again, holding the bony prominences, we turn baby half a circle, and we sweep the arm up and out, rotate the back uppermost again, and we rotate half a circle the other way, pressing down on the antecubical fossa of the arms. We then sweep the second arm out, and again we turn the baby back uppermost, and then we allow the baby to hang until we can see the nape of the neck, which we can see now. We're then going to place baby over our arm. This is the only time you might have some you might touch the cord because of the position that you're doing, and we're going to be doing Marisot Smelly Vite, and that's where you place your fingers on the cheekbones, being really careful not to place your fingers in the mouth. And then you're going to put your other hand on the back of the baby's occiput to aid flexion, and then with maternal effort,
Well done, Lucy.
you go up and over onto mum. And then we would do all the things that we would normally do for a delivery. So if mum wanted an active or a physiological third stage, we would ensure that that was provided. We would check for bleeding. We would deliver the placenta normally. But we would get the neonatal team just to check over baby because of being in the breech position. And their initial check would need to be completed by the neonatal team as well, rather than a sort of a midwife. So as I was saying, the neonatal team would need to perform the NIPE check because baby was in the breech position. So I'd then go on as normal to deliver the placenta and check the tears and just do the normal care, so maternal and fetal and neonatal observations. So I've shown you sort of the mechanisms and the manoeuvres for breech here, but with the theory we'll cover sort of the risk factors, fetal monitoring. So we would recommend continuous fetal monitoring if we had diagnosed an undiagnosed breech. We would also want you obviously to document contemporaneously, so we'd want a scribe in the room. To take cord gases because it has been a breech delivery, just to see whether there was any stress on the baby. We also might want to consider a Datex or an incident form. They're sometimes called different things via different trusts. Just because it was an undiagnosed breech, they can look back through the care and see whether there was any opportunities where we could have picked up that the presentation was breech. So there will be a lot more evidence and theory added to your actual lecture session and your online session, but this is sort of the simulation for the breech scenario. Hopefully you've enjoyed it. Thank you.